All right, quick introduction for our last speaker of the afternoon here. Dr. Bill Landers he's basically president of Orotech, which is known for their antimicrobial agents, delivery systems, and microbial tests for periodontal infections. He pioneered the development of phase contrast microscopy for dentistry and co-developed the antimicrobial agent Therasol and the ViaJet oral irrigator. He's widely known for his in-depth knowledge regarding bioscan phase contrast microscopy, enzymatic assays, DNA testing, and cultures. He's given hundreds of lectures at venues ranging from dental schools, dental hygiene schools, universities, government agencies, and dental hygiene societies. All right, he has been a featured columnist for the journal RDH magazine. His articles have been published in Contemporary Dental Hygiene as well as Modern Hygienist magazine. So please give a warm welcome, all right, to Dr. Bill Landers.
I have to read the disclosure statement here. I do have a financial interest in some of the products in my talk. I have not received any grant monies from any other companies involved. So that's also here on the first slide. So my company makes the microscopes that we'll be talking about and also the BANA enzyme assay if we have time to get to that. So let us begin. The IAOMT is going to have this lecture on their site. If you would like an expanded version of this, a 2-hour version of this 1-hour course, it will be on our own website. The site address isn't up yet, so call us at the 800 number and we'll put you a link to it when it's available. What we'll be talking about is some of the old historical theories about periodontal disease, its prevalence in the population, the etiology of the disease. That's important because it's the reason why you need to have microbiological testing in your office. And then we'll be talking about the traditional clinical tests, their limitations, microbiological tests, and we'll talk about outside laboratory tests and chairside tests in particular. About 47% of the US population has periodontal disease according to the NHAIS population study that's conducted by NIH periodically. That's a lot, and that underestimates the actual level of disease because their criteria was you had to have 2 millimeters of attachment loss at 2 or more sites. Obviously, you can have disease with fewer numbers of sites or less attachment loss and still have periodontal disease. So the number is probably considerably higher than that. But only about 0.5% of the population go to a dentist because of a known periodontal problem. So there's a total mismatch between the level of the disease in the population and those who are seeking care for it. Why so few? Public beliefs about periodontal disease is part of the problem. Most people think their periodontal health is good. Among men, well over half think their health is good, somewhat less for women. If you're a smoker, paradoxically, they think their health is pretty good by almost 3/4 or 2/3 of the population. Same for people of poor economic status, no high school, and it breaks down by men and women too. So why do people think they have such great periodontal health? We also have to ask ourselves why you go to the dentist, why people do go to the dentist. And all the usual reasons are listed there on the chart. But this tiny slice that you see right here is the number who go for periodontal problems, a periodontal and or gum problem. And as you see, it's just a tiny slice of people seeking dental care. The reason is most people get their information about dental diseases, gum diseases, not from their dentist or dental hygienist, but from the media, from advertisements for the myriad of dental products that are sold over the counter. Your opportunity to talk to the patient comes up once or twice a year typically, but they're bombarded with ads from these companies every day. So all the free samples that you get in your office for, Colgate and Crest and others, on the airways, they're giving the patients a totally different message. Let's look at some of those messages. So if you examine the boxes that the products come in or the labels on the product, you will see things like this. This is just the Crest box. I can't read that on my screen here. It would help if I had my glasses. Yeah, oh, they're there. So, anti-cavity and anti-gingivitis. And that is typical of all of the major brands that you'll find in the stores. So they're being told basically, use this toothpaste, use this mouthwash, and you won't have any gum problems. So why should they think that they're not healthy if they're using these products? And making it even worse, the ADA endorses these products. So not only is the company saying they will do this, but the ADA is endorsing the view that these products will do that. So how do you recover your credibility? How do you get them to believe what you're finding in the mouths as opposed to what the TV ads are saying? Well, you can't blame the manufacturers. They're just trying to make a buck and take advantage of an educational vacuum that's out there for information. What you need is proof, something that the patient can see that's undeniably shocking to them that they do, in fact, have an infection. And microbiological tests are that proof. By the way, how many people here already do microbiological testing? How many use an outside lab, like a DNA test? How many use a chairside, like microscope? Okay, so I'm preaching to the converted in some cases here. So, reviewing prevalence of the disease. Periodontal disease is a transmissible infection. It's not present at birth. We acquire the organisms through life, usually from mother to child. It affects well over half of Americans. Most people think they're not at risk. And only a small fraction of people are currently seeking professional help for their dental, for their periodontal problems. And where they're getting their information from is ads, not from their dentist or their dental hygienist. But we can reverse that, and we're going to show you how to do that today. The etiology of the disease is quite different than you probably learned in school. There are two criteria in order to have periodontal disease. You have to have both of these present. One, you have to have a pathogenic microflora. Paul Kai's proved back in the 70s, 60s, and 70s that without the organisms, you cannot have dental caries and you cannot have periodontal disease. It's only when you introduce those microbes that you get disease occurring in the subjects. Secondly, you have to have what is called in the literature a susceptible host, a term I don't like because it implies that there is something intrinsically wrong with the host. I think it's more accurate to say that you have a participating host, a willing host, an obliging host, somebody who is allowing these bugs to grow in their mouths as opposed to not having them and being healthy. Once you have both of those factors in place, then they trigger an immunological response that results in the clinical disease that you see every day. Surprisingly, the bacteria themselves, the pathogens, cause very little damage to the periodontium. What happens is they hijack our immune system and trick our immune system into doing the damage, to breaking down the connective tissue, to provide blood products, essentially. Interestingly, studies have shown that after a cleaning, periodontal disease tends to get worse in patients. Why? Because there's the blood that's created by all of the scaling, and that nourishes the pathogens, and you get an explosion in their numbers and an even worse spiral of immune system reaction to that. So that's the basic model of the etiology. So if you've got specific pathogens in our own immune system, essentially this is working like an autoimmune disease. It is our own immune system that is causing the damage. And this is turning out to be the case for a host of other systemic diseases. It's not uncommon for it to work this way. And it's the blood products that the bacteria are really after. There are microbiological differences between periodontal health and disease. In health, the microflora is largely gram-positive, aerobic, very few white blood cells present, and no spirochetes. Spirochetes are always present in periodontal disease, absent in health. And the field in general is non-modal. It's very specific. In periodontal disease, on the other hand, the flora switches. It becomes gram-negative for most of the organisms, anaerobic, and let me say a word about anaerobes. The term is misunderstood, I'm finding, and it doesn't mean that oxygen is going to kill these bugs. When microbiologists use the term, they're referring to growth rates. So anaerobic bacteria grow fastest when there's very little oxygen present in the environment. If oxygen is present, it doesn't kill them, it just suspends their growth rate. They don't grow very fast. An exception to that rule, of course, is ozone, which is not O2, that's O3, and it operates completely differently. But normal air oxygen doesn't affect them. It's also characterized by many, many white blood cells, too numerous to count, tons of spirochetes, too numerous to count, and the entire field impression that you get is of a high motility of the sample. But in particular, it's the white blood cells and the presence of spirochetes that are predictive of future loss of attachment. These organisms, we acquire them, they're free-floating organisms, they exist as individuals. It's only when they get together in coordinated groups of different species, each contributing their own to the whole, that they become pathogenic. It activates certain genes within these bacteria that turn them into pathogens. The bacteria are heaviest at the gingival margin initially, and then they migrate apically down the cemental surfaces to the most anaerobic portions of the pocket. There can be anywhere from 800 to 1,000 different microorganisms in your mouth, different species of microorganisms in your mouth. At any given time, we typically only have 100 to 200 species of those 1,000 that could be there, and they establish these collaborative colonies. They're competing not only with each other, but against other groups of organisms. So it's a very cooperative ecosystem. And it differs exquisitely by the site involved. You will find a different community of organisms on the facial aspect of a tooth as opposed to the lingual aspect of the tooth. So it's a highly specific environment that they grow in. How fast do these bugs grow? You'd be shocked. On average, they double in population in the mouth every 4.5 hours. So, you just take that exponentially, 2 times 2 times 2, every 4.5 hours. So, after 2 hours, if a patient, say, has been in your office for a cleaning and they're walking out the door, 2 hours later, most of the biofilm is already in the process of reforming itself. After 6 hours, it's pretty much fully reformed. Now, this would be a healthy biofilm that forms at first. It's only as that biofilm is allowed to remain in place that it becomes anaerobic over time. So that's why mechanical home care works so well, is it disrupts these biofilms, if they're doing it properly, so that they have to start the colonization process all over again. But after 6 hours, you've pretty much got a mature biofilm on the surfaces of the teeth. I said that contrary to prevailing wisdom, the bacteria do very little damage. So let's go into that a little bit more. It's inflammation generated by the host that does the damage to the periodontium. And it comes through 2 forms. One is called a passive form of damage, and that occurs when the white blood cells that have been recruited to the site of the infection die. They only have a 3-day lifespan. And during that lifespan, they use up the potent digestive enzymes within the white blood cells. And if they're used up, so when they die, there's no net effect on the tissue. But if the pathogenic microflora has the ability to up and down regulate over 100 genes in our white blood cells, so they can, in effect, force our white blood cells to certain behaviors and inhibit others. And one thing they do is they attract the white blood cells. They stimulate the pathway that manufactures white blood cells and gets them to the site of the infection. So they are delivered in larger numbers than normal to the site of the infection, but they're impotent. They're not allowed to phagocytose the bacteria. They're prevented from doing that by the pathogens. So 3 days later, they die naturally, and all of those enzymes are now released right out onto the tissue. And that accounts for about 50% of the destruction to the periodontium. The other half of the destruction occurs from a ramping up of the immune system. So we've got T cells floating around that are monitoring the situation, and they're basically saying, I don't care how many white blood cells you sent, we need more because the infection is still there. So the body ramps up production of white blood cells, and it tries to build a better roadway to get all of those white blood cells to the site of the infection. The problem is there's already tissue there, there's already connective tissue, so it intentionally starts breaking down that connective tissue to provide the physical space for a better capillary network to deliver more white blood cells to the site of the infection. So the destruction of the connective tissue is mediated by our immune system under the direction of the pathogenic bacteria. And once that vicious cycle gets started of more and more white blood cells being delivered to the inside of the infection and dying and releasing their digestive enzymes on the tissue, the destruction just keeps ramping up and up and up. We also find in the literature, everybody knows by now, that a lot of systemic diseases are tied to periodontal infections. The number, however, might surprise you. At least 57 systemic diseases have now been tied to periodontal disease. That's a lot. That's almost every disease you can think of. The biggest ones: cardiovascular disease, diabetes, rheumatoid arthritis, Alzheimer's. The list just goes on and on. This is just a partial list of some of the biggies. What's the common element between all of these? It's inflammation. Because these pathogens can up and down regulate our immune cells, this is a common mechanism that pathogens in other places in the body use as well. And once the immune system has been put on high alert by an oral infection, it's on high alert everywhere else in the body as well. So things that might have been marginal at one time, if you have an oral infection, then they're triggered to blow up big time. So these bacteria, in effect, control chemotaxis, the ability of our white blood cells to find where the infection is and go to it. They encourage that because they want the white blood cells there, and a host of other things that I won't get into here. So, different model completely of what periodontal is. Summing up, it's biofilm, not plaque. Biofilm communicates much better than plaque does what we're dealing with to the patients. All biofilms aren't pathogenic. You can have completely healthy biofilms, and initially all biofilms are healthy, only become pathogenic over time. It's the inflammation that does the damage, and gum disease increases the probability of medical disease as well, and the microbiology of health and disease are completely different. So let's talk about the traditional clinical armamentarium for diagnosing periodontal disease. You have, of course, disclosing solutions and radiographs and pocket depth measurements and clinical attachment measurements, bleeding on probing, and the appearance of the tissue. Let's take these one by one. Disclosing solutions are worthless. What are they staining? They're staining supragingival plaque. That's aerobic by definition. It's above the gum line. So it has nothing to do with disease, the visible plaque you see above the gum line. It's a good motivator, seeing all that red stuff on your teeth, of course, but it doesn't diagnose disease. So we can get rid of that. Radiographs. Radiographs are useful as a measure of a single point in time. They are not predictive of future loss of attachment, however. So when you see damage to the periodontium on a radiograph, you know that there has been an infection at some point in time. You don't know what the current state of that is. It may be damage that occurred 10 years ago and is stable today. So you can take those as a single time point measurement. And the most important thing to know about radiographs is that they do not correlate with future loss of attachment. Numerous studies have shown that. The one exception, of course, is an intact lamina dura. If that's in place, there's generally no further destruction, bone destruction, for at least 12 months, if that's extent. So let's move on to pocket depths. The pocket is not the disease, and this is where dental hygiene schools are teaching the wrong thing. The pocket is the enemy, the pocket is what you've got to eliminate, but the pocket is only a sequela of disease. It is not the disease itself, it's the result of the disease process. So you can have a 7 millimeter pocket that is healthy. Conversely, you can have a 2 millimeter normal sulcus that is diseased. Remember, everyone starts off with a shallow sulcus around their teeth. So the disease originates in shallow sites. You weren't born with all of these deep sites because of disease. You were born with healthy depths, and the disease process begins in those shallow sites. By the time a pocket is measurable, of course, the bone has already been lost. So it is a lagging indicator, as they say in statistics. Shallow sites are not protective because the disease starts in shallow sites. This is the biggest bugaboo about periodontal probing, and that is its accuracy, its reliability. A classic study occurred. It wasn't this old. I just like to put these old nurses on there for effect. But what they did is they gave a group of hygienists intensive 2-hour training sessions in the best probing techniques. And they used calibrated balances so that they were probing with exactly the right amount of force. And after 2 hours of instruction in the probing, these are hygienists who presumably already knew how to probe, they turned them loose and had them probe patients. And what they found was that as a result of all that training, there was no effect whatsoever on personal repeatability. That's the ability for one person to go into a pocket, measure it, come back out, go into the pocket, and come up with the same measurement again. So you can't even probe the same pocket twice in a row and get the same measurement oftentimes. Also, interpersonal reliability was not found, wasn't there. And that's the ability of one person to go into the pocket and get a measurement, and another person to go in the same pocket and get the same measurement. Doesn't happen. Why? Because there are so many confounding factors involved in it. Which of these periodontal probes is the more accurate? The one on the left with 1 millimeter markings, or the one on the right with 2 millimeter markings? Let's have a show of hand for 1 millimeter markings. Nobody likes 1 millimeter marked periodontal probes, okay. 2 millimeter marking probes, couple of hands. Well, the answer is neither of them. One is not more accurate over the other. Most people tend to pick B because it's got finer markings on it, so you can do more accurate measurement. Well, if that's the case, what of, instead of 1 millimeter markings, we put in 0.5 millimeter markings? Would it be twice as accurate? What if we put 1/4 millimeter markings on that probe? Would it now be 4 times more accurate? No. The markings you see in a probe are an illusion of precision. All the studies that have been done show that you can't measure anything less than 2 millimeters. The standard error of deviation in reading a periodontal probe is plus or minus 1 millimeter. So it's a 2 millimeter change that you have to have in order to know that what you're reading is actually what's there. Measurement changes of less than that are just statistical noise, they're error. So they provide an illusion of accuracy. And if you think that I know, I've never met a hygienist who didn't think she was the best periodontal prober in the world. So, they're drilled on this in school ad infinitum. But if you think you can measure changes of less than 1 millimeter, you're simply delusional. So, only changes over 2 millimeters are statistically significant. Single time points are meaningless. The AAP says you probe a pocket for 5 millimeters, doesn't mean anything. If you probe it over time and you're getting changes greater than 2 millimeters, yes, that is statistically significant and meaningful. So, summarizing periodontal probes. Periodontal disease is an infection, and you cannot measure infections with a notched metal stick. You need, if you're going to treat an infection, you have to have something that can determine whether an infection is present, i.e. you need a microbiological test. Bleeding on probing, one of the other sacred cows of clinical testing. It was already back in the 1980s that studies began appearing showing that bleeding on probing was a meaningless indicator. Studies, the classical study on this by Boyan in the literature, looked at bleeding on probing at baseline and then readings for attachment loss 3 and 6 months later, 3, 6, and 12 months later. And what they found, there was no correlation whatsoever between bleeding on probing and future attachment loss. Why? Well, yes, bleeding can be caused by periodontal disease, but it can also be caused by so many other things that you can't trust what's causing the bleeding. You only have a 50% chance of guessing the answer is due to disease. Half the time it's due to something else. Probing too hard is one of the big ones. The ideal probing force is 20 grams. If you take a periodontal probe and weigh it, it weighs 20 grams on average. So if you're probing a mandibular site and putting additional pressure on it more than the weight of the instrument, you're already probing too hard and getting the wrong measurements. What bleeding on probing is really measuring is capillary fragility. How likely, how liable is that tissue to break, the capillaries to break? And that can be affected by a host of things, and we'll mention just a few of them. For instance, aspirin. 5 times better, more likely to bleed on probing if a patient's taking aspirin than not. Do you ask that in your health histories? 1 in 3 people take daily aspirin for hypertensive reasons. Hypertension itself, all your hypertension meds increase capillary fragility. So about 1 out of every 4 people, adults anyway, is on hypertensive medications. So they're going to bleed more rapidly, more readily just because they're on a hypertensive med. Oral contraceptives, same thing, increased likelihood of bleeding. And there are others. So there are a host of problems with bleeding on probing. Summing it up, looking at all the studies and combining the data, this is the part that really worries about bleeding on probing. If the false positive ratio, which is the chance that the site is bleeding, but there is no actual disease present, is almost 30%. So that means almost 1 out of 3 patients that bleeds on probing isn't really diseased. And so you wind over-treating those patients because if you're going just on bleeding on probing, it looks like they're diseased. Worse than that, though, is the false negatives. And that's defined as a site that does not bleed, but nevertheless is already infected. And the number of false negatives is a whopping 88%. That means almost 9 out of 10 patients who do not bleed when you probe them in your office already have a periodontal infection. And you're missing it. And you're missing a chance to treat those patients early. Tissue tone, that's only a secondary symptom. It's not a primary symptom per AAP definition, sorry. So, clinical tests were developed a century ago. They were never designed to determine whether a patient has a microbial infection. They cannot measure microbial infections. And you have to do them for insurance purposes, but they really should be relegated to the trash heap of history. So we're going to look at things that diagnose disease much better than notch metal sticks and blood. So let's go over the microbiological tests. We'll take let's skip this, it's really not important. For those of you who aren't using a microscope, let me point out the profitability of them. Almost every one of our customers who gets a microscope winds up calling us back and saying, you know, they paid for it, usually in a window of about 2 to 4 months. And we're talking about, you know, a $5,000, dollar instrument. And the reason it pays back so fast is patients can't get enough of this stuff. They want to see what their bacteria look like from visit to visit, because that's a independent measurement of how well their home hygiene has been, as opposed to you looking in the mouth and saying, well, everything looks good today, see you in 3 months. So if you were seeing just 5 recall patients a day, 4 days a week, that's 20 recalls a week, with a test fee of $20, which is on the low side compared to what offices tell me they're charging. Your weekly test income, whoops, went too fast there. Your weekly test income would be $400 a week. You can buy any darn microscope you want for $400 a week income. And then once that's paid for, that's all gravy, the test income that you get. And patient acceptance, those of you who already have microscopes in the audience, raise your hands if you think this is a good patient motivator. Yeah, for sure, hands high. Nothing motivates a patient better than seeing their own bugs on a screen in front of them. So why has there been so little interest in microbiological testing among the profession? Primarily it's habit. Human beings are comfort machines. We don't like changing our routines much at all. We like things to be the same day after day. And so, we may think we want to change something in our process, but the momentum is against us. You've got to be proactive about it if you want to do it. So let's discuss the outside laboratories first. There are 2. One is genetic tests, and the other is cultural assays, where they grow them in an anaerobic environment. The best of the DNA test is a company called Oral DNA. They're located, I believe, in Minnesota someplace, and that's their telephone number. The way the test works is pretty simple. They give you a little vial, and you have the patient spit into it. That's then sent to their laboratory, and then they do their DNA thing on there and send you back a nice report that shows you what organisms they've found in what numbers. It's a convenient way to do the testing. It can test for about 8 different species on average. And they will give you antibiotic guidelines with your report. This doesn't mean this is the antibiotic to use. It's based on the literature, this bug responds to this antibiotic. A reason why I'm stressing that will come with the next test. So you can put that form in the patient's record. The disadvantage of DNA testing is the cost of the test is pretty steep. It runs anywhere from $99 to $125 or so per test. And there is a time lag involved because you have to send the test by mail or courier out to their labs, wait for the test to be done. Generally, they'll send you the reports by email or something, so you don't have to wait for time back to you. But in any case, the patient is no longer in the chair. If you find that there's a positive test, you've got to recontact the patient and get them back in the office again. So this is the test that I would recommend based on all the feedback I've had about it. Genomic tests, I thought I had deleted this slide. I don't even want to talk about those today. I don't think much about them. Anaerobic cultures. There used to be 4 labs that did it. We're now down to just a single lab in the country that does it. It's located in Philadelphia, Oral Microbiological Testing Service, run by Dr. Tom Rams. It's a terrific laboratory. I've been there many times. And they take your samples and they plate them on growth media and put them in anaerobic chambers. And it takes about 7 days for them to incubate and show every bug that could be there if they're going to be there. But the real advantage of the cultural assay is they also plate these organisms onto antibiotic plates. So they will tell you with absolute precision what antibiotics work against the bacteria the patient has. So if you're having any trouble at all with prescribing a systemic antibiotic, get yourself a cultural assay, and that'll reveal where the issue is. The advantages is the antibiotic sensitivity, of course. That would be number 1. They can check for about a dozen different species. The disadvantages, it's about a 2-week result or 2-week wait until you get your result. And the cost of the test is significant too. It's about $120 the last time I checked. They cannot test for spirochetes, but they use our microscopes to do that. So they take the sample and they'll also look at it under a microscope to see if there are spirochetes present. Why don't they test for spirochetes by growing them? You can't grow them. Nobody has been able to grow spirochetes. They're extremely fastidious. And it turns out that they actually require other species of organisms in order to grow. For instance, Treponema denicola, one of the more famous spirochetes, requires Porphyromonas gingivalis for its growth. They can't grow in absence of each other. Now, let's talk about the chairside tests that are available to you. And that is phase contrast microscopy and the Banner enzyme test. We'll talk about microscopy first. So there's the sourcing information. Again, this is my bias. This is our product, so you'll understand if I have a sweet spot in my heart for it. So the advantages of microscopy: one, it is chairside. You get your results in 1 minute, right while the patient is there. It takes no time at all to do it. It's the only test that can look at white blood cells and tell you whether there's an abundance of those in the sample or not. It is also the only way of looking at all the spirochetal species, of which there are 57 different spirochetal species. And I'll show you another chart in a second. I'll wait for that. The DNA test only tests for a single species, Treponema denicola. Patient motivation, as we've said, that is amazing. Disadvantages: there is a learning curve to using a microscope. You have to learn, how to use it and what you're looking at. They are expensive upfront costs, so you're talking about $5,000 to $6,000. There is ample proof in the literature that the presence of spirochetes is correlated with future loss of attachment. So this is a highly predictive feature to look for in your samples, whether there are spirochetes present. And interestingly, hang on a second here. Oh, okay, here's a video of a disease sample on the right and a healthy sample on the left. You don't have to be a microbiologist to see there's a huge difference between health and disease. Patients see that readily. We talked about test income, so we'll skip over that again. And patient motivation. Phase contrast is the only technique that we would recommend. It's the only kind of microscope we sell. But they are simultaneously phase contrast and also dark field if you want to do that. But phase contrast only shows you a more precise, crisper image than dark field does, because dark field has to bend light rays in order to get that effect. The guy who invented the technique won the Nobel Prize in 1956 for physics. So here's an ordinary conventional bright field microscope looking at a slide of E. coli, and you can't see them. And the reason is most bacteria are transparent to light. It just washes through them and you don't see any detail. You can stain them to bring out detail, but all of the stains are lethal to the organism, so you can only look at dead stained organisms. If you want to see them live, dark field or phase contrast, preferably, is the way to go. And here's the same slide viewed under phase contrast. You can see it just makes everything pop out that was invisible before. How do you prepare a slide? There are a couple of steps involved in doing that, and we'll go over them one by one for you. This is sort of a refresher for those who are already using it, and maybe new information for those who aren't. You always want to use new glassware. Don't reuse it, because the residual stuff that's on that will complicate the next test. They're considered sharps, by the way, for disposal. So you take a new slide, place it on a paper towel, handle it by its edges so you don't get anything on the flat surface of it. There's a particular type of slide that, I'm sorry, this is actually wrong. That's cover glasses have to be 1.5 thick. Thick is a idiosyncratic optical measurement. It doesn't mean thick as opposed to thin. Thick is the measurement, like millimeters or inches or what have you. It's thick. So you need to have cover glasses of 1.2 to 1.5 thick for phase contrast to work. You put a drop of Oraprep on the fresh slide. Oraprep is an artificial curvicular fluid. We learned decades ago that these bacteria don't do well if you change the salt environment that they're in. Saliva has a different salt component than distilled water, than normal saline, but we found out what it is in curvicular fluid, and that's what we manufacture in Oraprep. So you just put a drop of this on the slide so you can put your sample into the Oraprep, and they're going to feel right at home. It also prevents cell lysis. And these are things that you should never use, distilled water or normal saline. They will totally pop the bacteria and you won't even be able to see them at all. So after the aura prep, and all of this will be on your material so you can look at it slower later. You want to obtain your sample from the apical third of the deepest pockets that the patient has. Why? Because the deeper the pocket, the greater likelihood that it's going to be anaerobic. And that's what we want to see is the most anaerobic sample, because those will be, if the bugs are going to be there, that's where they'll be. You can pool the samples because it doesn't really make any difference where the site came from. If it's positive anywhere, you're going to have to treat the whole mouth because these bugs are motile. They're going to be colonizing every site they can. So you transfer your sample gently to the drop of aura prep. Place a cover glass onto the sample. Let it flop down at an angle, traps less gas underneath the cover glass. And then you flip it over and compress it, pressing down on it. You flip it over because if you press as hard as you need to, the cover glass will break. They're very thin. Turn it upside down, it's supported, so you're pressing on the thick glass. And how much pressure do you want to put? About as much as it takes to turn your fingernail white, to blanch your fingernail. So it's a fairly strong amount of pressure. Don't have to tap, just one firm push. Then, lastly, you apply aura seal along the four edges of the cover glass to seal it from outside air and evaporation. And that will eliminate the rivers that you typically see under conventional slides. It'll keep that sample alive and kicking for hours and hours, sometimes days. So the ideal time to examine the slide is about 15 to 20 minutes after it's been prepared. Some of the spirochetes, for instance, they're invisible. You can't see them on a freshly made slide, but they come crawling out of the woodwork if you just keep them alive long enough for about 15 minutes. So that's the ideal window to look at them. If you don't seal that slide, however, they're dead in 5 minutes. So seal your slides after you've placed the cover glass. And it's just painting it along all four edges. And then once you've prepared your slide with the cover glass, the microscope is only looking at a thin red band through your samples. You always want to move the fine focus knob up and down, so you move your focal plane up and down through the vertical space of your sample, see everything that's present. Non-risk factors that are in there are epithelial cells and red blood cells. These are not diagnostically significant, so we really don't care about them. I only point them out because you'll be seeing them. And that's what they look like on the microscope. And let's move on to white blood cells. A lot about, so this would be a healthy sample. It's boring. That's a live movie that you're looking at. Not much is happening there. And there's a total absence of spirochetes, a smattering of white blood cells. That's typically what you see in a healthy biofilm sample. On the risk factors that we see, white blood cells are right up there at the top of the list because that is the primary inflammatory cell. They're recruited to the site by the disease process. So you always want to look for the relative abundance of white blood cells in your samples. They're 12 microns in diameter, and that's what they look like on a slide. Freshly arrived, they'll be full of these little dancing dots called cytoplasmic granules. Those are depleted over time, so cells that are about to die, you won't see any of those at all inside the cell. And I'll skip over bradykinin in the interest of time here. That's an exception to the rule. Now, in early disease, the types of spirochetes you see will be the ones here at the bottom. They're loosely coiled, relatively short, very thin. As the conditions become more profoundly anaerobic over time, it encourages the growth of different species. So you get species that are longer, thicker, more tightly coiled. So you can do a differential diagnosis for how long-standing that biofilm has been pathogenic just by the types of spirochetes you see in it. You can see something that's relatively recently formed or clearly has been there for weeks and weeks and weeks just based on the species of spirochetes that you see. And I'm going to skip to a video of them so you can see these guys in real life here. These guys will, in pathogenic biofilms, they cooperate with each other. They behave cooperatively. They'll link up side to side and beat in unison, and you'll see that in the video here. Porphyromonas gingivalis, often seen in the literature, you can't see that on a microscope. Well, you can see it, but you can't tell what it is because it looks just like 20, 30, 40 other similar looking species, so we can't differentiate it. But if you see spirochetes in the sample, there is a very good chance that PG is also present because, again, they require each other for growth. And yeasts are the last risk factor that you see. Independent of spirochetes and other pathogens, yeasts by themselves can trigger an inflammatory reaction. So you do need to know what those look like under a microscope. And that's typically how they'll appear. Although sometimes you get these long tubules like that. My favorite bug, Trichomonas oralis. This is a protozoan, a one-celled animal. Like amoebae, one-celled animal. You won't find these in early infections. They only typically come in when in a very mature, advanced infection. So if you see them independent of anything else, you know that that infection has been there a long time. So it's a high risk factor if you see those. And that's what they look like in the sample. And apparently none of my videos are playing. Huh. I apologize for that. These are what amoebae look like. Those round bodies that you see inside the amoebae, those are white blood cells. That seems to be the favorite thing of amoebae, is eating up dead white blood cells. They'll go after those before they go after anything else. So I would categorize them as scavengers. They mainly are just picking up all this dead detritus there in the samples. And none of my videos want to work. Why is that? Okay, I think I'm just about out of my time here, correct? Yes, okay. I was going to talk about the Bannazyme enzyme test, but I won't. But it's there in the video for you.
All right, thank you, sir. Appreciate it.
You're welcome.